Hello students, welcome to the second part of this assessment of the nervous system chapter. We're going to talk about the neurologic changes associated with aging. Please pay attention. When I always teach, I always recommend first to be learning these facts and theory not only for your patients, but for the first line of care, which is your family. It's important for your father, your mother, your grandparents, okay? Pay attention to this. So neurologic changes associated with aging often affect the mobility and sensory perception, right? Mobility changes in late adulthood can cause slower movement and response time and a decrease in sensory perception as outlined in the patient-centered care box that we're going to check in a few seconds. Any problems that affect the nerves and muscles affect the motor and ADL abilities, okay? Sensory changes in older adults can also affect their ADLs. Pupils decrease in size. It's very important to know this, which restricts the amount of light entering the eye and adapt more slowly. That's why many patients sometimes they prefer to be in the darkness, right? In rooms that are dark instead of the full light of the sunlight of the day, unless they are the type of elderly that loves to walk and they are in the habit of walking every day and go to the park, which is unfortunately the less percentage of the elderly population. Touch sensation decreases, which may lead to falls because the older person may not feel small objects or a step underfoot. Falling should be a no-no, not only in the hospital, not only in the inpatient, but the outpatient. And the reason why is because a huge percentage of the elderly population that falls ended up with a fracture and problems with the femoral artery, and recover from that is not good. The prognosis of recovery is not good. Most of them die. So be careful with falls, okay? Be very careful with falls. Okay, so the patient-centered care, older adult health, the physiologic change, we mentioned the slow cognitive processing time, and that's good to know for test purposes, and recent memory loss. Instead of the long-term memory loss, the recent one is the one affected. The long-term is going to be, they are going to have, let me read this. Reinforced teaching by repetition using written reminders or electronic memory aids. So what happened is the recent memory is more affected. If they sometimes have a struggle remembering how they came to the hospital or what they did yesterday. However, the long term, right, is less affected. I remember my grandma, 105 years old. She remembered all the midwives. She had 8 kids and she remembered all the midwives, the names, the hospitals. So the long term was intact. However, the memory loss, the recent, was having trouble. Decreased sensory perception of touch. Remind patients to look where their feet are placed when walking, and this is another good to know. Possible change in perception of pain, change in sleep patterns. That's good to know because normal sleeping patterns are affected as we age, right? Sometimes patients start interrupting their sleep pattern in the middle of the night. They stay awake for 30 to 40 minutes and then some of them, they go back to sleep. Other people, they cannot go to sleep, so their circadian rhythm is affected. altered balance and or decreased coordination and increased risk for infection. Please monitor the patient carefully for signs and symptoms of infection, especially when they have altered mental status. Okay, sometimes they don't understand why, or they are not able to identify the infection, especially urinary tract infection, and they start changing their mental status. So that's something to monitor. Acute cognitive decline is frequently caused by drug interactions or toxicity by inadequate oxygen supply to the brain, hypoxia, for example. That's good to know. Toxicity could be meds or could be infection, okay, plus hypoxia. So this is coming in the test, okay? Remember the blood-brain barrier we studied before. These are elements that are able to cross the blood-brain barrier, including the glucose and alcohol and medications, anesthesia, right? Long-term memory often seems better, as I told you, than recall, recent, or immediate registration memory. Mental status may be impaired in the older adult as a result of infection, hypoxia, as I said, hypoglycemia, or hyperglycemia, any imbalance in glucose. During an acute change in mental status, assess for the adult for peripheral oxygenation, saturation levels, serum glucose, and potential infection. So how do you assess peripheral oxygenation? A good way is to check the pallor, okay, the O2 sat, of course, capillary refill, and skin temperature. Okay, that's the way you assess peripheral oxygenation. Let's go to health promotions, disease prevention. I am following every single slide in your PowerPoint. Okay, I don't want to leave nothing out of this. Young adults, especially men, are particularly at risk of engaging in risky physical activities such as motorcycle or car racing without wearing a helmet or diving into shallow water. Unfortunately, these activities often lead to serious spinal cord or traumatic brain injuries and should be avoided. All of you who wants to be working in ER, you are going to see a huge amount, is a big amount of patients with a spinal cord or traumatic brain injuries from accidents, especially car accidents, and recently from the use or problems with the scooters. A lot of patients having problems because of the scooters. Remind adults of age to avoid excessive alcohol or other substances that can impair judgment and cause any type of accident. Okay. Practicing a healthy lifestyle can help promote nervous system health. For example, smoking constricts blood vessels and can lead to decreased perfusion to the brain, resulting in a brain attack or stroke. So if you have any family member smoking at this point, you should try to get them out of this habit. Here is a question. The nurse performs an initial baseline neurologic assessment in an older client. Which of the following findings would the nurse expect for this client? Of course, long-term memory loss, we know is not affected. Inability to ambulate is not inability. It's a reduce motor movement, right? So ambulation is possible, but is reduced, is affected a little bit. It's not, the patient is not unable to walk. Acute confusion, no, it's not acute. The mental status decrease little by little. So it's altered balance. Let's recognize the cues: assessment, patient history, obtain information from the patient about health problems, drug therapy history. We know we have to to always think about the blood-brain barrier, smoking and substance abuse, history, occupation, and current lifestyle. Why occupation? Because these elderly patients, for example, some of them, they are living in neighborhoods that are affected. There are factories, the water is contaminated. Maybe they are living in a house with 4 kids, and the 4 of them are smoking. All these different factors, right? And probably they are still working, and they go to work to places where, even in their younger ages. Think about the firefighters and the police that work in 911, and they were in their 30s or 40s. Right now, they are having in their 70s. They are having problems because of this. The amount of smoke they inhale in that particular event. During your introduction, note the patient's appearance and assess speech ability, affect, and movement. If the patient seems to have cognition deficits or has trouble speaking or hearing, ask a family member or significant other to give you the full report. Physical disability or mental health disability, such as paralysis from a stroke or a spinal cord injury, or a neurocognitive disorder such as dementia or traumatic brain injury, also must be assessed. Mobility limitation requires many individuals to use ambulatory aids or wheelchairs, especially middle-aged and older adults. So also you need to check knowing the level of daily activity helps establish a baseline for later comparison as the patient improves or worsen. Chronic health conditions, including diabetes mellitus, hypertension, kidney disease, place patients at risk for neurologic health problems. Assess the use of alcohol, again, tobacco, recreational drugs, and other medications, especially for older adults who often experience adverse drug events. And you also assess for history of falls. Nutrition status. The nervous system functions and its optimal level when a person's nutritional intake is adequate to meet cellular needs. Okay? So the nervous system is going to be a reflection of what you eat. In addition to glucose and the amino acids needed to promote adequate neurologic function, vitamin B, especially B12, is the key participant in this nutritional aspect. So vitamin B12 and in general vitamin Bs, we have to include eggs, good quality eggs. There are many eggs right now that are coming with different levels of omega-3 included, right? Some eggs are having 70, some others they are having 140 and having 170. Depends on how the eggs are, if the hen is cage-free, right? If it's organic. Now, good quality beef, organ meats, and fish. Patients who consume a vegan diet can get adequate vitamin B from fortified grains, cereals, or bread. Talking about fish, make sure you get fish from places or water that are not having any radiation. Okay, that's very important. Family history and genetic tests, genetic risk. Family neurologic history such as stroke, always ask for that. Many neurologic diseases has a genetic basis such as migraine, headaches, and epilepsy. Believe it or not, these are hereditary and could be genetic in root, right? Current health, and that's good to know too. Current health problems, if they have assessed for pain, weakness, numbness, or cognitive impairment. And when you do the assessment in anything, for anything, use your mnemonic, all cards mnemonic. I'm not sure if you learned that, but for me, it worked wonders. The all cards mnemonic is going to help you assess the onset of any condition, location, duration, character, aggravating or relieving factors, timing, and severity. When we talk aggravating or relieving factors, we are talking since all the way from any event that caused the disease, or maybe a side effect of medication, as well as relieving factors. It could be an event, it could be every time that I do my meditation, this relieves the condition, or every time that I take my ibuprofen, this relieves the condition. Okay, so you have to go deep into. As you see, they are mentioning here the time, date and time of onset. Pretty much this could be adapted to the all cards mnemonic. Assess the intensity of pain by using a pain scale. Quality of pain may be described as burning, aching, or stabbing. Patients describe the pain in their own words and point to its location. Do never put an adjective to qualify a pain in the mouth of a patient. Let the patient express themselves. Weakness may be related to individual muscles or muscle groups. Determine whether weakness occurs in proximal or distal muscles or muscle groups. Distal weakness and impaired sensory perception, especially in the lower extremities, may indicate neuropathy, a problem in nerve tissue. Muscle weakness and or numbness in lower extremities may increase the risk for falls and injury. Again, this is a repetitive information, but we need to absorb this and try to assess not only our patients, but the members of our family. Weakness and or numbness in the upper extremities may interfere with mobility and functional ability. We know that. Impaired cognition may occur suddenly as a result of acute trauma to the brain. If they fall, for example, if they are practicing skating, okay, in Central Park, in Lincoln Center, and suddenly they fall, and they fall in the base, in the occipital area of the brain, you need to assess for cognition. But this one is going to be suddenly the impaired cognition as a result of acute trauma to the brain, or more slowly over years as a result of dementia or other disorder. Patients with impaired cognition may not be able to provide information about their symptoms, so ask a family member. Physical assessment. Two types of neurologic assessment may be performed. This is very important. Pay attention. A complete comprehensive assessment and a focus assessment. The bed staff nurses, which are all the nurses in different units, med surg, telemetry, the oncology unit, they are going to perform focused neurologic assessment. On the other side, primary healthcare providers and neuroscience ICU nurses, they are going to perform complete neurologic examination. It's more extensive. How do you assess the level of consciousness? And this is good to know. We need to know that this refers to the degree of alertness or amount of stimulation needed to engage a patient attention. Amount of stimulation needed to engage patient's attention, and that is going to be included in the Glasgow Coma Scale, and can range from alert to comatose. The patient who is described as alert is awake, engaged, and responsive, okay? A patient may be alert but not oriented to person, place, or time, okay? You can be talking to a neighborhood in the church and suddenly you start talking about where is your home, and she doesn't know, but she was praying next to you in the church. Or maybe she doesn't know what is the month, right? Or maybe she doesn't know the current president, okay? So she could be alert but not oriented. Patients who are less than alert are labeled lethargic, stuporous, or comatose. A lethargic patient is drowsy but easily awakened, right? Usually by touching the patient. One who is arousable only with vigorous or painful stimulation is stuporous. The one who is arousable only with vigorous or painful stimulation is stuporous. The comatose patient is unconscious and cannot be aroused despite vigorous or nauseous stimulation. So here is a way that you can remember the level of consciousness: alert, voice responsive, pain responsive, and responsive. Okay. This is called the ABPU method, APU method. Neurologic assessment of the awake and alert patient. Okay, there is going to be two neurologic assessments, to the awake and alert and the unconscious. Let's focus on the awake and alert patient. The NERS includes 5 components in the baseline focus assessment, which includes the following: level of consciousness, language and speech, cranial nerve status, movement and sensation, and vital signs. So the assessment of level of consciousness of the awake and alert patient, the ones who are alert and awake, allows the nurse to perform several components of the exam, such as mobility, because they are alert, so they are going to be able to follow commands. Language and speech, they are going to be able to understand what you are saying and to reply. And cognition, to evaluate alertness, call patients by their name or touch them gently. Do not use painful stimuli unless the patient level of consciousness decreases, okay? To evaluate awareness, once the patient attention is engaged, ask questions to determine orientation. Responses that indicate orientation includes the ability to answer questions about person, place, time, and situations, such as the person ability to relate the onset of symptoms. Here comes your old cards mnemonic. The name of the primary healthcare provider or nurse, the year, the month, the home address, the name of the healthcare agency. So if you use your old card mnemonic, if the patient is able to remember when the onset of the disease started, the patient is alert to time, and so on. The nurse documents findings for a patient who is fully alert and oriented as alert and oriented times 4, right? Fully conscious patients should be able to respond coherently unless they have dementia or delirium. Loss of memory, especially recent memory, tends to be an early sign of neurologic problems, especially in older adults when they are driving and they don't remember where they parked their cars, for example, yesterday or this morning. Be aware that patients' literacy level, sensory ability, hearing, and vision, and age generation can affect their responses, and this is good to know. Let's go to assessment of language and speech of the alert and oriented patient. Language and speech can be assessed during the initial interview. Language skills include understanding the spoken or written word and being able to coherently speak or write. Let's remember what part of the brain is having the Broca and the Wernicke, okay? You have to review that. I'm not going to tell you. Patients may demonstrate understanding by following directions on admissions. For example, get undressed, right? Speech is assessed as being normal, slow, garbled, nonsensical, difficult to find words, or other impairments. If the change in speech is new and represents a deterioration from a previous ability to communicate, this change must be urgently reported to the primary healthcare provider because it may indicate a stroke, new onset of confusion, or other serious neurologic conditions. Probably they are in diabetic coma. Okay, their sugars are above 700, and they start the brain fog is transitioning to a worse scenario. Be careful. Assessment of cranial nerve status, okay, of the alert and oriented. Typically tested to establish a baseline from which to compare progress or deterioration. Damage or malfunction of cranial nerves can cause either unilateral or bilateral dysfunction. In a baseline focus assessment, which is the assessment done by the bedside nurse of an alert and oriented patient, the evaluation should include vision, visual fields, and all of this is NCLEX material alert. Please master this. I've seen these questions in different sources, okay? NCLEX material alert, what I'm going to read right now. Vision fields, and pupil reaction. Know the function of your cranial nerves 2 and 3 by having patients read text, checking for peripheral vision and assessing pupil response. Facial asymmetry, your cranial nerve 7, by observing the patient's entire face and comparing sides. So, for example, here, if you have your patient with trigeminal neuralgia, okay, or Bell's palsy, you're going to find differences. Swallowing, your cranial nerve 9 and 10, by observing the patient swallow unless the patient is MPO. Extraocular movements, your cranial nerve 3, 4, and 5, by observing the unusual eye movements such as strabismus, inward or outward deviation of the eye. If the patient, for example, you're going to see some patients with third cranial nerve palsy. Third cranial nerve palsy is a condition in which the eye, one of the eyes goes outward and downward. The other one is going to be in a normal regular condition, and the other one, and the, let's say the left, is going to be outward and downward. So they are not going to be able to make the full extraocular movements. Pupils should be equal in size, round and regular in shape, and react to light and accommodation. This is your perla. And I'm sure you know this, but I'm going to review it because that's something that you need to master when you do your neurological condition in any settings, especially in the hospital. Okay, so let's review this.
So first, I'm going to shine a bright light in your left eye. Just keep looking straight ahead, please. Okay. Now we'll do the other side. Good. Now I'll do the same thing again, but when I shine the light in his left eye, I will check the pupil on the right side because the pupils constrict together at the same rate, even though I'm only shining the light in one pupil. So when I shine the light in the left eye now, I'm going to check the right pupil and make sure that it constricts at the same rate that the left one does, and it did, and I'll do the same thing again on this side. Okay, good. So we've now assessed that the pupils are equal, they're round, reactive to light, and then the accommodation part, I usually hold the pen in front of the patient about a foot or so in front of their face, and then ask them to focus on an object that's further away. And what I check is for the pupils to accommodate, which means that when the patient focuses on something closer to them, the pupils constrict, but when the object that they focus on is further away, the pupils have to accommodate and they actually dilate. So in this case, I'm going to hold the pen right here above the camera and ask you to look at the pen, and then look at the place on the wall. And look at the pen again, and look at the wall. And here this is a very slight reaction, but the accommodation was there, and the reason is that this room is not very big, so he can't look very far away. But that is how we checked if the pupils are equal, round, reactive to light, and accommodation.
Thank you so much for that explanation. And we're going to go back to the textbook. So you know Perla, right? Perla. Patients who have had eye surgery for cataracts or glaucoma often have irregular shaped pupils. To test for pupil constriction, dim the room lights and ask the patient to close both eyes, and just basically you can conduct the assessment that we saw in the video, and is in this book they are describing in detail how to do it. During the cranial nerve assessment, look for asymmetry, such as unequal movement in the facial muscles, for example, as I mentioned, Bell's palsy, a peripheral nervous system disorder, which is caused for a virus. Okay, we're gonna get into deep into that later. And they have paralysis of all facial muscles on the affected side, also called facial paralysis. The patient cannot close the eye on the affected side, wrinkle the forehead, smile, whistle, or grimace. Tearing may stop or become excessive. The face appears, because they cannot close the eyes, right? The face appears mask-like and sags. Taste is usually impaired to some degree, but the symptoms seldom persist beyond the second week of paralysis. This has been lately studied to find the relationship between Bell's palsy and COVID-19. Not only the COVID-19 itself, the presence of the virus, but also as a side effect of the vaccines. They are still until further investigation. There are some evidence that are, in fact, telling us that this is occurring, but some others are saying it's not related. So it's still under investigation. Severe intermittent facial pain is consistent with trigeminal neuralgia, a persistent, painful, and debilitating disorder that involves trigeminal cranial nerve 5. And you are going to check in when you study your cranial nerve 5 and the trigeminal neuralgia, all the muscles that are affected in the shape of a W, if we put the fingers, on next to the end of the eye, in the outside part, is going to be affecting the eyebrows, the eyes, and probably the muscles below the eye. Assessment of movement and sensation, still talking about the alert and oriented and aware patient. If possible, assess the patient gait and balance. That's good to know. Patients must eat food at room temperature, not either cold. And sorry, I forgot to mention this when we were talking about trigeminal neuralgia. That's good to know. Also, Bell's palsy is coming in the exam, because these patients are having problems in 3 different areas, and they cannot move one side of, or they are going to have persistent pain and debilitating disorders that involve the trigeminal cranial nerve 5. So we need to educate the patients on different therapies to reduce the pain, right? And for example, if they need to eat, the best scenario is to have to get them eat food at room temperature. So that's gonna decrease the pain. If they eat hot food or very cold, the pain is going to be worse. Now let's go to the assessment of movement and sensation. Assess the patient's gait and balance. An altered gait and balance may be an indication of cerebellar dysfunction. Certain medications, especially hypertensive medications, medications for dysrhythmias and conditions like heart failure can also cause these problems. So, as we were talking before, the balance and the gait is related to the nerves and proper nutrition. We mentioned that. So if the patient is eating a lot of cholesterol, the triglycerides are going to be elevated, causing hypertension. This also is going to cause dysrhythmias and heart failure. Okay, so nutrition. Observe the patient for involuntary tremors or movements. Describe these movements as accurately as possible, such as pill rolling with the thumbs and fingers at rest, or intention tremors of both hands. These abnormalities can indicate certain conditions, such as multiple sclerosis. In addition, assess the patient for movements that indicate irritability, hyperactivity, or slow movements. Measure the patient hand strength by asking the patient to grasp and squeeze 2 fingers of each of your hands. Compare the grasp for equality of strength. And here comes another that's good to know. The acuity level of the patient determines how often the sensory assessment is done. For example, patients with acute spinal cord trauma or ascending Guillain-Barré syndrome, and I am going to start suggesting you a good way to remember Guillain-Barré. The first 2 letters are G and U, meaning the disease goes up. GU, disease goes up. Okay, there are many neurological conditions you need to get. You need to be a master on how do you remember these conditions. Okay, Guillain-Barré, the disease goes up. It's ascending syndrome, and these are assessed every hour until stable, and then every 4 hours, because the condition keeps getting worse. So you need to you need to assess very often. This is a rare acute inflammatory disorder that affects the axons and or myelin of the peripheral nerve system. And let's remember that the peripheral nerve system are all the nerves that are not in the spinal, neither the brain, are the extremities, the lumbar, right? The extremities, the arms, and the legs, resulting in ascending muscle weakness or paralysis. And if the condition does not improve, because during the treatment, and we are going to see that later, during the treatment they are going to receive immunoglobulins, IV immunoglobulins, trying to stop that autoimmune attack. So if the disease does not improve, respiratory failure may result in death. So it's going to start with the weakness, paralysis in the lower extremities, maybe in the feet, then goes to the calf, then goes to the thighs, and suddenly the arms, and it's going up, and it's going to start involving the respiratory muscles and nerves. So that's good to know. And this is, whatever I'm saying, is going to be NCLEX material alert, especially because Guillain-Barré is very related nowadays with COVID-19 and vaccinations. So this is an NCLEX alert. These patients will need electrocardiograms and intubation trays at bedside. So you're doing your assessment every hour, every 4 hours. It's not for nothing. That means that's the speed in which the disease progresses. So if you have a patient that suddenly in the morning was having weakness in the thighs and the legs, and suddenly the patient is reporting this weakness in the hands and the around the elbows, the next thing is going to happen is a respiratory failure. So be ready with your electrocardiograms and intubation trays at the bedside. Pain and other abnormal sensory findings may have CNS or PNS cause. For example, the neuropathies of diabetes mellitus, malnutrition, and vascular problems have a PNS cause. Okay, assessment of the patient with altered consciousness. So now we switch from the alert to the patient with level of consciousness is altered. So for a baseline focus assessment, the nurse includes 4 components instead of 5, right? So they are going to include the level of consciousness, the cranial nerves, motor response, vital signs. In this assessment, we are not going to assess language and speech. The patient is having altered consciousness, right? How to assess for level of consciousness? We're going to use the Glasgow Coma Scale. And this is basically divided in 3 parts. We're going to assess the eye opening, the motor response, and the verbal response. The lower the score, the lower the patient's neurologic function. A full alert patient has a total score of 15, so a total score of 7 or less indicates the patient is comatose. So here is the Glasgow Coma Scale. You can see the score for every section: the eye opening, the motor response, the verbal response. You see the score from 1 to 4 in terms of eye opening. The motor response is a score from 1 to 6. The verbal from 1 to 5. Okay. Remember, we have 2 types of nursing assessment. One is the focus assessment, which is done by the bedside nurse, and the other one is the comprehensive, which is done by primary care providers and neurologic ICU nurses. That's more extensive. So let's watch the video about the Glasgow Coma Scale assessment so you can have a better understanding. Okay.
Okay guys, today we're going to talk about assessing the Glasgow Coma Scale, better known as the GCS, or better abbreviated as the GCS. There's 3 components to assessing the GCS. There's an eye component, a voice component, and a motor component. So Kumar today is pretending to be a patient who has been involved in a trauma, and Irla is going to come down to him in the emergency department, and as part of his assessment is going to assess his Glasgow Coma score. So Irla is going to show you what that involves now.
Kumar, hello, can you hear me? Can you tell me what happened? Kumar, can you hear me?
Okay, so he's not doing anything there. He's not responding to Irla in any way. He's not moving, he's not opening his eyes. He's not saying anything. So Irla has now to give Kumar a painful stimulus. We have some options to give a painful stimulus. One of our options is supraorbital pressure. So that's above the eyes, and Irla would press really firmly. He's not going to do it today because Kumar is awake, but in reality he would press really firmly. And you see, okay, Kumar is just making incomprehensible sounds. He opened his eyes briefly and flexed his arms. Our other options for painful stimulus is trapezius. So see how firmly Irla would squeeze on the trapezius muscle. We don't tend to do sternal rubs anymore, so where someone used to put the knuckles on the sternum and give a good firm rub up and down the sternum, it can damage tissue, particularly if you're doing it again and again, so we don't do it so commonly. Our 4th option is nail bed pressure. So you take a pen, you place it across the patient's nail bed, and you press down really hard on the nail bed to see what kind of response you get from the patient. So there's some options for delivering a painful stimulus. If someone is obviously quite awake, you do not need to do that. You should be able to assess their GCS without doing it, but that's how we deliver a stimulus. So when we delivered a painful stimulus to Kumar, he briefly opened his eyes. You see the eyes flickered open and closed again. That gives him a score of E2, eyes 2. He just moaned and groaned, so incomprehensible sounds. So for the voice component, he got a V2. And then for the motor component, all he did was flex his arms up and then they fell back down again. He didn't localize the pain. He didn't bat away Irla's hand where it was giving him a painful stimulus. That gives him a motor score of 3. So that's E2, V2, M3, giving him a total GCS score of 7, which is quite low and something we would often find in a trauma patient, a GCS of 7.
Excellent. This was an excellent video, and that's why I really like to do my lectures with videos, because when I verbally explain all of these facts, especially in the neurologic chapter, we have to see to understand, okay? We have to see to understand. It's much better than going through a PowerPoint, okay? It takes a little bit longer, but the amount of information and the details we provide is going to be much better, and you're going to understand better as well. Okay, so you have here the scale. Make notice. You see when the answer relates to the eye opening and all the different stages, the motor response and the verbal response on the Glasgow Coma Scale. Assessment of the cranial nerve status. Okay, so for this assessment, in the altered consciousness aspect, we're going to evaluate the pupil reaction, your cranial nerve 2 and 3, your corneal reflex cranial nerve 5 and 7, and the gag and cough reflex cranial nerve 9 and 10. You see this patient, the abnormal posturing, the image on this is the left, right? The left side is the corticate posturing, meaning the patient is touching the core, the heart, in Latin the core, corazón. Okay, so when he is touching the heart is the corticate, that's the name. But when the arms are moving outwards, right, it's called the cerebrate, the image on the right side, the cerebrate. Okay, to assess the patient pupils, opens the eyes and observe for any abnormal eye movement, such as nystagmus, is involuntary eye movement that may cause the eyes to rapidly move from side to side, up and down, or in circles. Also, assess the side of shape of the pupil, and all this assessment is on the Perla video, so go and watch the video again. If the patient is comatose, assess for corneal reflex to ensure that eyes are protected to prevent corneal abrasion. Use a small piece of cotton on the eyelid and observe for blinking. Avoid making direct contact with the cornea to prevent abrasion. If unsure about whether the patient has a gag or cough reflex, assess the patient by lightly touching the back of the tongue with a tongue blade. Okay. Assessment of the motor response in an unconscious patient, right? A patient with a level of consciousness problems. Observe the patient for movement, being sure to compare the right and left sides. Note any asymmetry of abnormal positions of the head, extremities, and trunk of the body. If the patient has no spontaneous movement, lift the patient's arms one at a time and let them drop to the bed. This is a good assessment, but make sure something is, on the bed. Like you can put a pillow. You don't want to drop the arm of the patient and cause another more pain. For example, if they hit a table or the border, the frame of the bed, right? A weak or paralyzed arm falls more freely than one that has intact muscle innervation. The patients who are comatose, the cortication is abnormal motor movement seen in the patient with lesions that interrupt the corticospinal pathway. So they are going to have the arms touching their heart, the cortication. The patient arms, wrists, and fingers are flexed with internal rotation and plantar flexion to the legs. This rotation is abnormal movement, as we saw, with rigidity characterized by extension of the arms and legs, pronation of the arms, plantar flexion, and opistotonos, which is the body spasm in which the body is bowed forward. Vital signs. The brain estimates regular blood pressure, heart rate, and respirations. And we remember the brain estimates has the pons, the medulla, right, and the midbrain. So you go back to that part of this chapter and review that. The pons, the medulla, and the midbrain. When intracranial pressure increases, the Cushing reflex is triggered, causing hypertension with a widened pulse pressure, bradycardia, and irregular respiratory rate. And this is NCLEX material alert. Master this. The Cushing reflex, okay? They are going to present the scenarios with the numeric numbers in terms of bradycardia, respiratory rate, heart rate, your blood pressure, and they are going to ask you if these signs are related to intracranial pressure. Okay, they are going to present different values, so you have to master this, know your blood pressure and levels, your respiration and heart rate levels, so you can identify which are related to the Cushing reflex. Okay, psychosocial assessment. For example, patients who have a mild stroke and no lasting neurologic deficits are less likely to be severely depressed than patients who experience a loss of independent movement or impaired communication as a result of a stroke. Of course, that is very depressing, right? And depression can result in cognitive and behavioral changes that are similar to delirium or dementia. Okay, let me repeat. Depression can result in cognitive and behavioral changes that are similar to delirium or dementia. Depression is a common mental health disorder that is often missed in a variety of healthcare settings, especially in settings that are care for older adults. That is why we use depression screening tools, and sometimes in primary care we do this screening very fast. So we just, because we have a lot of patients in primary care, and the average time in primary care, the time in the visit is 10 to 15 minutes, right? In 10 to 15 minutes, you want to do the assessment, you want to check the laboratory results, you want to do the prescriptions, and maybe physical assessment. It's impossible. So that's why the screenings are not done properly. In hospitals, inpatient, right? Inpatient settings, we have more time. So we try to do this the proper way and to give the time, the necessary time to understand the signs and symptoms. So thank you for your attention. When we come back, we are going to check all the laboratory assessment and imaging needed for this assessment of the nervous system in order to understand the diagnosis. Thank you.